3, 2, 1. Realize.
So, ma'am, we are going live in 3, 2, 1, and live. Good afternoon, viewers. On behalf of DocPlexus, I am Kajal Mukherjee, welcoming you all to this session of case-based learning from NHL Ahmedabad Medical College. Pregnancy-induced hypertension is a common complication that develops after 20 weeks of gestation and can pose significant risks to both mother and baby. It is characterized by elevated blood pressure without pre-existing hypertension and may progress to more severe conditions such as preeclampsia. Early diagnosis, close monitoring, and timely management are crucial to improve the maternal and fetal outcomes. For today's sessions, it's my privilege to introduce Chairperson Dr. Pushpa Yadava, Professor, OBG Departments, NHL Medical College, Ahmedabad. Moderator for today's sessions are Dr. Kruti Deliwala, Associate Professors, NHL Medical College, Ahmedabad, and Dr. Aayushi Amarnath Suthar, Assistant Professor, SVP IMSR, Ahmedabad. Dr. Dixita Kyada, second year resident from Gynec Department, SVP Hospital, Ahmedabad, will present her case today. Without further delay, I hand it over to Dr. Pushpa Yadava. Over to you, ma'am.
Thank you, Kajal bhai. Good afternoon, everyone. Today, Dr. Dixita is going to present a case on pregnancy-induced hypertension and further complicated by preeclampsia. So without further delay, let us just start this session. Dixita, you can start your presentation.
Okay. Good evening, everyone. I'm presenting today case of preeclampsia. The 35-year-old Hindu female patient named Kajal, coming from middle socioeconomic class, residing at Ahmedabad, working as a housewife, admitted to hospital due to elevated blood pressure on 13th August 2024. Patient is second gravida, previous CS, 8 months, 15 days of amenorrhea. Her LMP was 15th December 2023, and her calculated EDD, expected date of delivery, was 22nd September 2024. Her past menstrual is in past menstrual regular 30 days cycle with a flow lasting for 5 days, moderate quantity with no pain or passing of clots. History of presenting complaint: patient with a history of hypertensive disorder in previous pregnancy with normal BP recording till now in this present pregnancy, was found to elevated BP recording at a routine antenatal checkup. No history of a blurring of vision, headache, vomiting, breathlessness, bleeding PV, discharge PV, or a decreased urine output. Obstetric history: she has a full-term CS for 3 years, male child. Indication for that CS was gestational hypertension with fetal growth retardation. Her active married life was 6 years. In personal history, her diet was vegetarian, appetite normal, bowel, bladder regular, addiction, non-addiction. During physical examination, patient is conscious, cooperative, and well oriented to time, place, and person. Patient is well built with height 160 centimeter and weight 90 kg. Her BMI was 35, which is in obese category. On examination, there is a bilateral pedal edema up to the ankle. No pallor, icterus, or sinuses present. Temperature was normal. Pulse was 88 per minute, regular in good volume. Her BP was 170 by 110 mmHg. Respiratory rate was 14 per minute. In respiratory examination, there is a bilateral airway entry present. In cardiac examination, there is S1 and S2 present, no murmur present. In past history, patient has a history of gestational hypertension in previous pregnancy, which was resolved after 3 months of postpartum. Patient was on tablet Ecosprin 150 mg OD since 3 months of amenorrhea in this pregnancy. No history of diabetes, TB, jaundice, asthma, or drug allergy, or bleeding or blood transfusion reaction. There is no such a family history. During abdominal examination, there is a 34-week fundal height was 34-week. Presentation was cephalic. There is a fetal heart sound which is regular and located on a left on LOA position. Uterus was relaxed. There is a transverse scar of previous pregnancy. No scar tenderness was present. On per speculum examination, there is a normal cervix. On vaginal examination, there is a os closed, no show, no leak. Then on investigation, her hemoglobin was 12, platelet was 1 lakh, blood group A positive, LFT was normal. On her urine albumin was on a dipstick, there is a +2, which is 1. LDH is 225, which is normal. Uric acid was 0.4, which is normal, and her POEC profile was also normal. So the provisional diagnosis is 35-year-old second gravida at 36 week, presented with preeclampsia, not in labor. And for this, patient was get admitted due to the elevated BP. Prophylactic dose of injection magnesium sulfate was given, antihypertensive also given, and termination of pregnancy done via the lower uterine cesarean section.
So Dixita, we would label this as a late onset preeclampsia. And in your antenatal examinations, was she never found to be in the category of hypertensive patient? Did you find any hypertension in the previous antenatal visits?
No.
Or did she come directly with this high blood pressure?
No, the patient was followed regularly in antenatal visit, but there is no elevated blood pressure. At the 36-week patient present with elevated blood pressure.
So if you have two categories of patient, one with early onset hypertension and this one as she is presented post 36 weeks, which one do you think would have a poor prognosis?
Patient presented with early preeclampsia.
Dixita, do you think how early preeclampsia is dangerous to the, whether it is dangerous to the mother or to the fetus, and how? You said early preeclampsia is dangerous. So whether it is dangerous to the fetus more or mother more, and how?
It's dangerous to fetus more because there is a fetal growth restriction.
So what complications do you expect? Suppose this lady had increased blood pressure very early on, say by 20 weeks only. What sequelae would you expect in that kind of pregnancy, and how would you monitor, and when would you like to terminate it?
If it's before 24 week with severe preeclampsia, then termination, or after 34 week with severe preeclampsia, then termination of pregnancy is done. If it is between the 24 to 34 week, then the conservative management done. Patient get admitted, then ask patient to rest, minimum 10 hours of rest. Then BP should be checked every 4 hourly. Fetal heart sound should be monitored twice a daily. and USG for the Doppler done twice a weekly. And if it is less than 34 weeks, then injection and corticosteroid coverage should be done. And if it still get worsened, then termination of pregnancy is done, whichever gestational of age.
In case you are trying to terminate around, say, 32 weeks, what else apart from corticosteroids are we giving? And for what reason?
Magnesium sulfate is given for the neuroprotection.
So what complications do you expect the fetus to undergo when you have a pregnancy, which is like having a pregnancy-induced hypertensive patient?
Aayushi, oligohydramnios, fetal asphyxia or sudden fetal death.
And what complications can occur to the mother?
In mother, there is in antenatal there is chances of eclampsia. It may converted into HELP, or in intranatally there is chances of eclampsia also, and postpartum hemorrhage, and in postnatal there is chances of eclampsia and shock.
Would you say that abruptio is also much more common in such patients?
Abruptio DIC.
Okay. So how would this patient present, and how would you investigate such a patient where you suspect that she is having abruptio presenti?
Then patient came with a complaint of bleeding PV and decreased fetal movement. And for investigation, we check for the USG. There is a sign of abruption present or not, or in investigation.
How do you check for abruption?
Before doing the USG, any clinical examination, would you confirm by clinical examination what are the
Yes,
signs and symptoms that are in favor of abruption in a case of PH? Clinically?
There, uterus is constantly contracted, tense and tender on per abdominal examination. On PV examination, there is a active bleeding is present.
Maybe it can be a concealed hemorrhage also. So
Concealed
it
Size
might be
of the
present.
uterus might correspond to the weeks of the gestation, or it might more than the weeks of gestation in case of abruption. If it is the concealed abruption, then the size will be more.
More, yes.
Now come to the sonography findings.
In USG, there is a retroplacental hemorrhage is seen in case of abruption.
Okay, so that is
In
present.
every
Where is it present, that hemorrhage? And how does it look like? I think we are doing quite a bit of sonography, so you should be able to describe what is the sonographic features of where you suspect that there is a hematoma.
Homogeneous in appearance.
Okay. And where is it present? Is it in front of the placenta? Is it in the amniotic fluid, amniotic cavity, or
Placental space.
so it is between the placenta and the myometrium, right? Suppose you find that the patient has already lost her fetus. Fetus is already dead. When does that happen? How much placental loss do you suspect if that has occurred?
Madam want to ask how much separation of the placenta will lead to the fetal death?
More than 10%.
It's more than almost 70 to 80% placental separation that will lead to fetal loss. Okay, so if fetus is still alive, you still have chances of saving that fetus. Now, in this case, she is a case of previous cesarean. So what problems, like how would you prepare such a patient? What investigations would you want? And what difficulties do you expect when you operate on her?
In this, there is a previous history of cesarean section. So, first to look out for the placental site. If it's anterior, then there is a chances of placenta previa, which was earlier diagnosed. But in this case, there is no such a placenta previa. On investigation, first we have to do normal hemoglobin count, then the platelet count, liver function test in which LDH, SGOT, SGPT, in renal function test, urea and creatinine, and the coagulation profile in which PT, APTT, D-dimer, fibrinogen, and FDP.
Okay, so before taking off a cesarean, what else would you want something to be kept ready?
Ma'am, in case PPT is not required, should you stop sharing?
That you can stop.
Dixita, can you stop, Dr. Dixita?
Yeah. So when you're taking her for cesarean section, what we need to keep the blood bottles ready, isn't it?
Yes.
And what difficulties do you expect when we are operating on such a patient?
There are high chances of intranet during operation. There is high chances of patient may get convulsed,
Okay.
or if its platelet count is lower, coagulation profile is altered, then hemostasis might get delayed.
Right. So we have to ask for blood transfusion and which components? Do we need to keep blood bottles ready before we take her for cesarean?
Yes.
Why?
And
Suppose like in her case, her hemoglobin is 12, but still we expect that we should have at least 2 PCVs ready. Why is that?
Because in preeclampsia there is a hemo concentration, so the hemoglobin is might falsely raised, and there are
Right.
chances of PPH. So
We are anticipating that there might be postpartum hemorrhage, right?
other components apart from PCB, what would you like to keep ready?
PRC, ma'am.
Before
is one
PRC, platelet
count.
count is adequate, then would you like to give PRC?
FFP, ma'am, fresh frozen plasma.
Why it is to be given?
So why do we need to transfuse FFP? How does it help?
Is there if coagulation profile is altered, then need for fresh
We
frozen
do
plasma.
expect that if there is element of abruption, there might be chances that the coagulation profile, if it is not altered, it might get altered. So we are already anticipating and preparing for that. Right? Now we come to the operative part. Like, what problems do you anticipate in operations? She is a case of previous cesarean. So operative difficulties because she is a case of previous cesarean. What difficulty might you encounter?
There is adhesion between the uterus and other organs, so, or high chances of a bladder is advanced.
Yeah, and we are in a hurry, so there might be injury
Ruptured or intestinal
in the baby. So once you have put an incision and delivered the baby, what other operative difficulties would you encounter? Suppose there is an extension of the incision.
Might get uterine artery ruptured, or hematoma may be developed.
Okay, so how would you tackle that?
Uterine artery, if it's uterine artery, bleeding is constant.
Okay, so
How will
how
you ligate the uterine artery? And what is the stepwise revascularization?
By the uterine artery ligation done by the O'Leary method.
Yes, how is it done? Can you describe it? I'm sure you must have either seen or you must have done it also. So how is it done?
We have done it today only.
So you try to palpate the uterine artery and then the needle is inserted, isn't it?
Yeah.
And we come right into the uterine cavity and then we go out again. So we are trying to incorporate the uterine artery which is bleeding. Okay, so this is one thing. Second thing is that we have to ensure that the bladder is not damaged because many times bladder is advanced, and if baby is already distressed, we are in a hurry to deliver the baby. So we should ensure that there is no harm to the bladder. How will you check for that?
Before the CS, we put the police catheterization done, so the check for the urine color.
Okay, so it should be clear.
Clear.
Yes. and
Apart from that,
for-
anything else? Apart from color of urine, we have opened the abdomen. Incision is yet we have not closed. Would you like to examine for the dome of the bladder and how
Dome
will
of the
you
bladder.
see? Then dome of the bladder we have examined. Then any other method to confirm if the urine is clear and still we are thinking we have not injured the bladder. Any other method during per operative procedure?
Retrograde filling of the bladder with methylene blue dye.
Yes, we are doing the retrograde filling of the bladder to confirm we have not injured the bladder. These are the methods by which we can confirm intraoperatively.
Yes.
Suppose she has started to bleed, there is postpartum hemorrhage. How will you tackle such a problem?
There is a two IV line access taken, and first we have to arrange for we already kept the blood is ready, so the PCV, FFP and PRC given in a 4:4 ratio. And if first we have to give medical management, in which we give the uterotonics like oxytocin or carboprost or methargine, and
Oxytocin given? And what dose? Oxytocin in what dose?
20 international unit IV.
In? Is it straight bolus or is it an infusion?
Diluted in a straight bolus, ma'am.
20 units will give bolus?
In 500 ml RL.
Yes, so it is an
We are giving
infusion.
infusion.
Okay, what else do we give then?
Carboprost.
So is it injectable, IV,
IM?
IM? How is it given?
Intramuscular, by intramuscular route, 250 microgram.
Can it be repeated?
Yes, it can be
How
repeated.
many times? How many doses? And at what interval?
Maximum up to 8 doses.
3 doses.
3 doses.
Okay, at least a 15-minute interval we can repeat it. So it has to be given only IM, no IV.
No,
Can it be given intramyometrial?
yes, it can be given.
Okay, so when you have opened for LSES and if she is bleeding, you can give in the myometrium also. Okay,
Yeah.
so in spite of this, still she is bleeding, uterus is still flabby, what else would you do?
Then there, if medical management is failed, then there is try to balloon.
Newer drug for
Bimanual
medical
massage.
newer drug for medical management. You have forgotten one thing.
Misoprostol.
Apart from misoprostol, carbetocin. What is the dose and how will you give? Okay. If medical management fails, then how will you proceed?
Then there is a balloon tamponade, or if it's a bimanual massage is done, or a balloon tamponade, or if it's also failed, then there is a compressing suture like a B-Lynch suture or a Cho suture is done. And if it's
How will
also
Chaw suture taken? How will you take Chaw suture? Have you seen it being taken anytime?
I see one case of B Lynch suture, ma'am.
Okay, so you can describe that. How is that taken?
For B Lynch suture, if it's intraoperatively during the LSES, the first entry point is 3 centimeter below the uterine incision, and second entry is in 3 centimeter above the upper edge of the uterine incision, then goes to posteriorly, and then the third entry is the same level as of first entry, and posteriorly intraluminal. Then the fourth entry is also on the other side, and come
What
into
material used for this?
CAD,
What needle?
chromic catgut, ma'am.
Chromic catgut and preferably straight needle.
Straight needle.
Okay. Right. So even if this fails, in spite of your compression sutures, the uterus is still flabby and patient is bleeding. What else can you do?
Uterine artery ligation or internal
They have
iliac
already
ligation. Then the
So
last
next is
resort
interiliac, and the last resort is abdominal, I mean
hysterectomy.
obstetric hysterectomy.
Obstetric hysterectomy.
Can you just describe the steps? Just mention the steps quickly.
In obstetric hysterectomy, if patient is ovary and fallopian tube are not removed, the first clamp is put over the round ligament, which is cut and transfixed. Then second clamp is placed over the cornual structure, which is also cut and transfixed. Then the third clamp placed over the uterine artery, which is only ligated, and the fourth clamp was on uterosacral ligament. And if it's and then last clamp at if we want
How will
is
you
obstetric
identify cervix?
hysterectomy different from a normal hysterectomy?
cervix is half
Dilated.
cervix is also
Fully dilated. How will you identify? And what Madam said, how the obstetric hysterectomy is different than the routine hysterectomy. What is the difference between these two?
I think the steps till uterosacral are almost the same, except the uterus is, the size is bigger, so you may have to apply more number of clamps. Right? Now, how will you identify the cervix and then open the vagina?
cervix has a circular muscle, and consistency is different from the uterus.
But you already have an open incision, isn't it? So you can either put your finger, go through the cervix, and then identify that this is the level of the vagina where you need to insert. Only thing is you will have to deglove and wear the gloves again.
Okay.
Okay, so you can put a nick and then go circular all around. Okay, so once you have removed the uterus, what else would you do before you close the abdomen?
Check for the every suture we tied for the there is a hemostasis achieved or not. And
Okay. Would you like to keep a drain,
yes,
abdominal drain? Why?
abdominal drain. Because in case of if there is a altered coagulation profile, there might chances of bleeding intra-abdominally, which
So even in the post-op, she can go under DIC. So we are just taking a precaution, isn't it? So that is one drain. Anywhere else would you like to keep a drain? In the subcutaneous tissue, would you like to keep a
Subcutaneous
negative drain?
yes.
So that is also again the same reason that we can drain the excess of bleeding that might get accumulated in the post-op period. Now, what problems do you expect patient may have in the post-op period? And how will you tackle?
Patient may get convulsion or a stroke or a sepsis. And
Right.
for
So
that
for
we have to
conversions,
do,
how would you manage?
sorry,
For conversions, how would you manage?
first stabilize the patient and put a mouth gag in the mouth, prevent the tongue bite, and injection magnesium sulfate is given, which is given by the IV or IM regime. In IM regime, known as a Pichards regime, in loading dose of 4 gram IV, 20% solution is given, and 50% concentration of 5 gram given on each buttock. This is for the loading dose. For maintenance dose, 50% of concentration, 5 gram magnesium sulfate given on buttock, given on alternate buttock 4 hours apart till the delivery of the baby or last conversion, whichever is last.
How
Right,
how
so-
the 20% and 50% solution? Max,
For,
what is the dose of max ampule and how will you convert it 20% and how will you convert it 50%?
The ampule is for 2 ml, in which 1 gram MgSO4 is there. So we for 20% solution, we have to take 4 ampule and diluted in 8, which is 8 ml, and diluted in 12 ml NS, which is 20% 4 gram MgSO4. And for 50%, there for 50% already 1 ampule 1 gram 2 ml, so it's already 50 ml percentage.
And you have to give deep iron, right?
Deep
So that should be taken care of. Deep intramuscular injection has to be given.
How will you monitor the max self? You have said if we are giving for 24 hours. How will you monitor?
We have to check for the SpO2, respiratory rate, deep tendon reflexes, and urine output.
How much should be the urine output?
More than 30 ml per hour.
Okay, suppose urine output is less. What will you do? Will you stop magnesium sulfate or you can wait and then give again?
We can wait and give again. We should skip the 1 dose and then give next dose.
Yeah, so whenever it reaches that level, then you can delay and that give that dose, right?
Yes.
Any other drug which can be given for convergence?
Midazolam is given. Thiopenton is also given. Lorazepam is given.
Livera is also given nowadays. Any other questions? Aayushi, if you want to ask anything. It's a huge topic, but I think for now this is enough. We have grilled her enough. Mr. Kajal, I think we would like to end up here.
Yeah, ma'am. With your permission, if there is no
Yeah.
other questions, I will end up here.
If you have any questions on the chat box, we will definitely answer
ma'am,
them.
Ma'am, we have not received any question as on time. So I
Right.
think most of the questions has been already been prompted from your side and Dr. Kruti's side. So I will just go with your permission, ma'am. I will close this session. So thank Dr.
Thank you.
Dixita for an interesting case presentation. Not only you have done the good case presentation, you have successfully answered all the volleys of questions which has been thrown towards you from by Dr. Pushpa and Dr. Kruti. My sincere thanks to Dr. Pushpa ma'am, Dr. Kruti, Dr. Aayushi for their expert inputs and their active participations on this session. I'm sure that this will help the HCP and PGs across India to utilize the learning in their day-to-day practice. And PGs especially will learn how to tackle the questions which are coming from their experts panel of faculties. Those who have missed this knowledge field event can see it recorded in the DocPlexus platform on the past event tab. So please look forward for DocPlexus platform for more interesting session like this. With this, I request Dr. Pushpa to say some final words. Ma'am, over to you.
Thank you, Mr. Kajal. This was a good session, and it really encourages our PGs to participate and learn how to present online. So it's a good experience, I think. And we will certainly be looking forward to many more such sessions. Thank you so much.
Thank you very much, ma'am. Thanks.
Thank you.
Thank you. Thank you so